Thank you, Dr. Ritter and Dr. Pugh, for the privilege of being here and being part of this discussion. There have been a number of other venues, some of you I'm sure have been at, where some of these themes have come up at the meeting, and hopefully this will provide some new as well as some reinforcing information. I have nothing to disclose. So when we think about this theme of how we assess skill, I just want to highlight at the outset that I don't think this is an area we have been as strong at as our patient population, the public, might ask of us. When we go to a surgeon, what the public wants to know, or what we want to know if we go to a colleague, is can they actually do the operation that we're seeing them for, that we know that must correlate with outcome. And as surgeons, we see the differences between good and bad technique based on experience or the conduct of the operation. But if you ask how we actually attest to that for the public, when we get our initial board certification, it's pretty much based on your program director's attestation and your case log, volume of experience without really an assessment of the quality thereof. For the ACGME perspective, in terms of program accreditation, it relies on case logs, and the programs are judged by their board pass rates. But again, none of that immediately or in a direct way factors in technical skill. And even in continuous certification out in practice, we're monitoring things like the loss of adverse licensure actions and your chair's attestation, not any kind of direct assessment of skill. And yet we know that there's a variability in patient outcomes, and we talk about that a lot at our meetings and monitor it in our hospitals. So despite these measures, we know we really haven't achieved standardization. One reflection of the variability of our product from our training paradigm, it was reflected in this paper by Rachel Kells, I'm sure some of you have seen before, back in JAMA Surgery in 2016. And Rachel used a combined database model to trace the outcomes of patient care to a surgical provider's residency program of origin, and paralleling some work that had previously been done in the OB-GYN literature by David Ash. She was able to group surgeons by tertiles related to their residency program of origin and show that long-term outcomes on important things like length of stay, failure to rescue, mortality from operative interventions, and surgical complications were able to be correlated with where you trained. Now, this in a way sounds more scary than perhaps it is. It turned out that you had to transfer about 14,000 patients from a third tertile performer to a first tertile to save a death, to prevent a death. So it's not like the level of care is grossly poor, but it is clearly illustrated that there are opportunities to improve the variability in our training outcome within our current training paradigm, and I think many of us recognize that. So with that background, in 2013, again, paper that I'm sure most, if not all of you have seen or read, the landmark paper in the New England Journal from Birkmeyer and colleagues looking at video-based assessment of skill by a peer on a performance of a bariatric bypass operation, and showed that there was a correlation with patient outcomes, including any complications, surgical complications, and even medical complications related to the surgical care, and the identified skill level as assessed by a peer colleague based on review of a video performance. And this obviously opened up the idea that some of these issues around how to assess our skill and how to potentially impact patient outcomes by doing so for practicing surgeons came into the forefront of our discussions. This is a more recent article that applied that in colectomy by Jonas Stolberg and a group from Northwestern. Two things that I think were highlighted in this study were that they could show that the statistically significant differences in outcomes that could be predicted based on the scoring of the skill level of a video-based performance of a single colectomy not only correlated with colectomy outcomes, but when they looked broadly at NSQIP data, all of that given surgeons' surgical outcomes, regardless of the procedure, could be shown to correlate with the scores on that single video-based assessment of a colectomy by a peer. And to give added validity to what they were taking away from the study or concluding from the study, when they looked at complications that really shouldn't be related to technical skill so much, such as surgical site infection, the correlations were not present. So some really important things to think about, how broad the applicability of this information could be based on a pretty limited data set. They also did some follow-up work, and this is just highlighting what I just said, that where I have the arrow is the quote in their discussion about the way this could be extrapolated to that surgeons' outcomes in general and not just for colectomy. They also then extrapolated this to look at oncologic outcomes using some other databases, and were able to show that if you eliminated early perioperative deaths, so that you're really looking at long-term outcomes that theoretically should be related to the quality of the oncologic care, there was a correlation of the skill level as predicted by the video-based assessment with long-term patient survivable, again, presumably related to the oncologic outcome, and also to lymph node counts, interestingly. Although all groups achieved an adequate number of lymph nodes, skill level definitely correlated still with the number of lymph nodes harvested. So beginning to raise the question, is this not just about complications from surgery, but in high-stakes games like oncologic surgery with the ultimate patient outcome measured far hence from the operative events? This doesn't hold up for everything in every study. This was a study by Dimmick and his group looking at various complications of sleeve gastrectomy, and you can see that there were statistically significant differences in outcomes related to video-based assessment of skill for surgical complications overall, and also for hemorrhage and reoperation. But for stricture and leak, the correlation was not there. So it's not to say that we found the panacea for assessing risk and skill and its relation to patient outcomes in every domain, but certainly many domains are proving to be accessible this way as more and more literature is coming to bear. Another question that comes up as we think broadly about the scalability of these approaches is, do we have to use a pure surgeon's time to do these assessments? And this was a paper presented here at this meeting in 2017 and published in Surgical Endoscopy, looking at crowdsourced assessment. And there's other studies that have shown similar findings. Basically, there's a little bit of a regression to the mean, I would say, as a summative statement about crowd-based assessment. That works pretty well for the average performer and is a little less distinguishing at the lower and higher ends of the skill spectrum, but certainly suggests that resources other than surgeons' time to do the assessment could be used for a pretty broad swath of where most of us might fall in our skill level. And then Dr. Ritter here on the panel was very instrumental in leading this work, or in leading the panel today. But SAGES has leaned into this, I think, in a wonderful way as part of the master's program being developed under Matt's leadership of the Education Council. They did a deep dive into laparoscopic Nissen fundoplication as an anchoring procedure in the master's pathway for the foregut area specifically. And through work with subject matter experts and an iterative process, a Delphi-type process, came up with a very robust strategy for how we might assess skill. And I guess what I'm trying to say by this is that not only is the observation that assessments can be meaningful in predicting patient outcomes and informing how we continue to grow and document our skill as surgeons, but the kind of tools that would allow this to do this in a very standardized way and in a way that could be very helpful, especially in a formative sense to the developing surgeon, are being developed through programs that SAGES has been working on. This is just a quick table, listed tabular form from that paper around some of the key areas of the operation that were deemed to be important, not only in terms of their immediate implications, but in terms of the future implications of that surgeon's practice. And this is the scoring rubric, which again will become, I think, Matt could speak much more to this, but I think will become a model for how we will build these assessments into the master's pathway, and also a model for how we might really make the assessment tools we use the most scientific and the best based on things that should predict outcomes for patients in the future. The American Board of Surgery has become interested in this, and you'll notice a heavy population of people who are either active leaders in SAGES or in this area of video-based assessment, and also in the case of Dr. Pryor and Dr. Beiske, very active in leadership with the board at this time. But the board is looking at this as perhaps the first opportunity we have had to meaningfully and in a feasible and scalable way bring real skill assessment into the ongoing assessment of a surgeon's practice. And a pilot's being launched with 3 different industry partners that are in this space already. It was quickly oversubscribed with interest. The carrot being offered is credit towards CME. If you participate, you'll submit a couple videos, you'll score a couple videos, and the idea is to start looking at whether this could be used as part of continuous certification for board-certified surgeons as a way of documenting, but even more importantly, improving our skills as we go through the course of our careers. This is just the announcement about that program. So just to provide this quick overview for the panel as a whole, we've long inferred skill by attestation, but haven't documented this well objectively, I would say. The availability of widespread video capture through the minimally invasive revolution really has created the substrate to think about this differently. And increasing data, as we've shared a little bit of, suggests that this is realistic, scalable, and correlates well with important patient outcomes. So there's a potential here to impact our career-long skill development in ways that we see in athletics and other disciplines, but have neglected, I would say, in our profession, and even our notions of professionalism about how we support, interact with, and help develop one another for the benefit of our patients in an ongoing way as part of our career commitment. Thank you very much.